drugs. Moving on to the next talk. This is on what are the anterior segment findings in drug toxicity. The talk will be given by Dr. Sindhu, Associate Professor in Ophthalmology, Government Medical College, Ernakulam.
Good morning, everybody. Today's talk is on anterior segment manifestations of systemic drug toxicity. After a drug molecule enters the systemic circulation, it can reach ocular tissue through the uveal or retinal circulation. The choroid, sclera, and the ciliary body have thin fenestrated walls for drug molecules to pass. A small lipid-soluble molecules pass freely into the chesuma and can further diffuse into the avascular structures such as lens, cornea, and trabecular meshwork. The major accumulation sites of systemic drugs are cornea, lens, and vitreous. Cornea has a permeable endothelium, and the stromal glycosaminoglycans can bind drug molecules, leading to the edema and decreased transparency of the cornea. The drug molecules also bind to the lens protein and photosensitize the lens to UV radiation. Longer the duration of drug in the eye increases the chance of toxicity. Coming to the drugs affecting the cornea, amiodarone, chloroquine and hydroxychloroquine, amantadine, and gold and silver are the most commonest drugs affecting cornea. The most commonest corneal manifestation in drug toxicity is vortex keratopathy or corneal verticillata. It is a fine golden brown opacity forming an irregular horizontal line in the lower corneal epithelium of both eyes, similar to that of a common age-related Husserl-Stanley line. Several irregular branching horizontal lines form a pattern resembling the whiskers of a cat. With an increasing number of the branches, a whorled pattern develops centered on the point below the pupil and swelling outwards, usually sparing the limbus. So, amiodarone is the most commonest drug causing vortex keratopathy. Amiodarone is a cardiac antiarrhythmic agent. Higher the dose and the longer the duration of the use, more substantial the corneal changes. Vision is minimally impaired in around 5% of the patients with a loss of single line of Snellen's acuity and mild blurring and halos. The keratopathy reverses on discontinuation of the drug. This is a slow process. Can also cause anterior subcapsular lens deposits and optic neuropathy. Even though amiodarone vortex keratopathy is a bilateral condition, unilateral case also has been reported. Chloroquine and hydroxychloroquine also cause vortex keratopathy. Chloroquine, this is drug used in autoimmune connective tissue diseases and in the treatment and prophylaxis of malaria. Unlike chloroquine retinopathy, corneal involvement has no relation with the duration of the drug usage. The changes are usually reversible on cessation of the therapy and sometimes clear despite of continuation of administration. And chlorpromazine is used as a sedative and to treat psychotic mental illness. On long-term therapy may develop subtle diffuse yellow-brown granular deposits in the corneal endothelium, Descemet's membrane, and deep stroma. Anterior lens capsule deposits and retinopathy may also seen. Argyrosis is a discoloration of ocular tissue. Secondary to silver deposits may be iatrogenic or from an occupational exposure. The keratopathy is characterized by grayish-brown granular deposits in the Descemet's membrane. Conjunctival discoloration may also be seen. Coming to chrysiasis, it's a deposition of gold in the living tissue and typically occurs after prolonged administration. Gold is used in the treatment of rheumatoid arthritis, and a total dose of gold compound usage exceeding 1500 mg can cause corneal deposits. The signs include the dust-like or glittering purple granules scattered throughout the epithelium and the stroma, concentrated in the deep layers and the periphery. It is not an indication for cessation of therapy. It may be associated with lens deposits or marginal keratitis. Amantadine is an oral agent used in the treatment of Parkinson's disease and related conditions. Some patients may develop diffuse white punctate opacities that may be associated with epithelial edema. And coming to the drugs affecting the lens, steroids is the main culprit in this. Route of administration of the steroids can be systemic, topical steroids, or nasal route. The resultant opacities are initially posterior subcapsular with subsequent anterior subcapsular involvement. Children are more susceptible than adults. Higher the dose and length of the treatment associated with a greater risk. Early opacity may regress if steroids are discontinued. Sometimes the cataract progression may warrant cataract surgery. Excessive use of topical steroids can also cause posterior subcapsular cataract and secondary glaucoma. Chlorpromazine, gold, and allopurinol are the other drugs affecting lens. Ciliary effusion, topiramate is an anticonvulsant and is also used in the treatment of migraine. It can cause acute angle closure, glaucoma with an associated myopia secondary to ciliocoroidal effusion. Presentation is usually within 1 month of starting the treatment with blurred vision and sometimes halos, ocular pain and redness. Signs include shallowing of the anterior chamber and raised intraocular pressure. The treatment consists of reducing the intraocular pressure and stopping the drug. Prognosis is usually good provided the complication is recognized. So picture showing ciliary effusion with an angle closure glaucoma. The drugs causing uveitis is rifabutin, which is used in the tuberculosis. And signs include acute anterior uveitis associated with the hypopyon. The drugs inhibiting metabolism of rifabutin like clarithromycin, fluconazole may increase the risk. Treatment is withdrawal of the drugs. The pseudofovir is a drug used in cytomegalovirus retinitis in acute AIDS, and it presents as acute anterior uveitis with few cells but marked fibrinous exudates. It may be associated with vitritis. Topical steroids and midratics as the treatment. Drugs causing uveitis, bisphosphonate used in the osteoporosis is the another drug. And systemic administration of fluoroquinolone antibiotics, particularly moxifloxacin, can cause acute pigment dispersion, causing bilateral acute transillumination illumination defects and bilateral acute depigmentation of the iris. It can be associated with other classical symptoms like conjunctival infection, eye pain, blurred vision, temporary ocular hypertonia, fixed and dilated pupils. Thank you, that's all.
Thank you, Dr. Sindhu, for shining the torch into the anterior segment.